This is another episode of Clot Conversations from the ISTH. This episode of Clot Conversations is different from our previous episodes since we're partnering with the INNOVTE network. INNOVTE is an independent, not-for-profit network of academic research groups that exists to promote international collaboration between academic research networks that conduct venous thromboembolism-related clinical research and to enhance the profile, science, and impact of investigator-led VTE clinical research. For a list of the partner organizations, take a look at the episode notes. The participants in this episode are all competitors in the Dragons Den competition at the ISTH. Dragons Den is based on the popular reality TV series Shark Tank. But in this version, 3 clinical investigators pitch their VTE research studies in front of a live audience to an expert panel of dragons for a chance to win funding towards their project and network endorsement. I'm joined on this episode by one of my co-hosts, Dr. Jamil Abdurrahman, who has taken on the task of interviewing each of the participants. First, we'll start with Dr. Francis Couturaud, who presented on the INNOVTE study, prognosis improvement of unprovoked venous thromboembolism with the use of shared decision-making process, including a time-dependent multi-component risk prediction scores intervention. Dr. Couturaud.
Hi, everybody. I'm Francis Couturaud. I am professor in medicine in Brest University in France, and I am the head of the JETBO research unit on venous thromboembolism.
Thank you. And you talked today about the INNOVTE study, which is looking at patients with unprovoked VTE and then choosing patients who should get continued anticoagulation and who should not. Can you tell us a bit about that?
Yes. Today, it persists a gap regarding this important question. And we have even more question. The first question is, should we extend or not treatment? And the second one, if we extend, should we reduce or not the dose? So lots of discussion with the patients is important here. And so in this project, we aimed to build a tool that combines a qualitative component and a quantitative component integrated into a shared decision-making process in order to better estimate the risk of recurrence, the risk of bleeding for patients, but also to work with the patients regarding perceptions of risk, preferences, preferred outcome. And so we want to improve not only the prognosis of venous thromboembolism, but also satisfactions of patients during the follow-up in this study.
Thank you. And where are you right now in progress with the study?
At this stage, we are building this multi-component tool. So it is well advanced, but we need one additional year to be fine with the final version of the tool in order to validate this tool in a step-to-age cluster randomized trial, which is the THANZ study, where the aim is to validate this tool. But at this stage, we have clinical variables, very interesting biochemical biomarkers, and we are working on imaging biomarkers. And all the patients' interviews have been done. So today, the tool is well advanced with the quantitative and the qualitative components.
So once the study is published, tell me about how it's going to be used. Give me a case. What kind of patients you'd see, how you'd use the tool, and how they would benefit from that.
I think one of the most interesting situation is the patients where the risk of recurrence could be intermediate, the risk of bleeding could be moderate or even high. And here, it's particularly important to have the perceptions of patients regarding the risk. We are not all the same regarding risks in life. And so some patients does not want to have an additional pulmonary embolism. We know that in 1/3 of cases, these patients have post-traumatic stress syndrome. And so for some patients, it is unbelievable to have another pulmonary embolism. But for other patients, they will be very afraid about bleeding risk. So when such recurrence risk and bleeding risk would be close here the tool will be determinant, I think.
Thank you. Yeah, it's very interesting. It's always a challenging discussion with the patient. Do we continue? Do we stop? And definitely having this data, looking at all these variables will make that decision a lot more simple. And I think the patients definitely appreciate that. Thank you so much for your time. I look forward to the study.
Thank you very much.
And thank you for participating today. We really appreciate it. Next, we have Dr. Leslie Skeith, who presented on the PARTUM Study, postpartum aspirin to reduce thromboembolism, undue morbidity.
Hi, I'm Leslie Skeith from the University of Calgary.
Perfect. So Leslie, thank you for speaking with us today. You spoke with us today about the PARTUM study. So you previously completed the pilot study and this is the full study. Can you tell us a bit about the PARTUM study?
Absolutely. This is a definitive large trial of a non-inferiority open-label trial of low-dose aspirin for 6 weeks compared to usual care low molecular weight heparin for women who are in the postpartum period who have VTE risk factors. We're looking to see if aspirin is non-inferior to usual care at preventing VTE, trying to offer an option that is simple, low cost, accessible, and may have an improved safety profile.
Thank you. Can you tell us why the study is important?
Well, we know VTE risk factors are common postpartum, and for challenges of giving low molecular weight heparin, this will really shift the care of postpartum individuals with VTE risk to something that we can really take or become more accessible globally.
Thank you. Can you tell us a bit about where you are now in the study and what are the next steps?
We completed the pilot PARTUM trial, which was published in the Lancet Hematology, that showed overall that aspirin was a feasible and acceptable option for postpartum individuals with VTE risk factors. So we've now are working and launching the full PARTUM trial. We have some early funds to start the trial in Canada, and we're now applying globally to work on us expanding this. We have 11 countries and 7 research networks who are part of the PARTUM trial, and we're just getting started.
Perfect. Thanks so much, Leslie. Is there anything else you want to add? Okay, great. Thanks so much for your time. We look forward to the study.
Finally, Dr. Emma Leitinger, who presented the Butterfly Study, the efficacy and acceptability of low molecular weight heparin administration via a subcutaneous catheter versus subcutaneous injections in both prophylactic and therapeutic settings.
Thank you. My name's Emma Leitinger. I'm one of the haematologists and PhD candidates in Melbourne, Australia. So I work mostly at Monash Health and Monash University. This study has been a couple of years in the making and excited that it's at this point now.
Great. So can you give us some background on the Butterfly Study? What are the challenges with long-term use of low molecular heparin? And how can a subcutaneous catheter work?
Thank you. Yeah. So as I'm sure many of the audience would be aware, there are a number of patients who require long-term low molecular weight heparins. The most common one that we deal with in Australia is Clexane, but there are others available as well. So frequently we see pregnant patients, but also a lot of patients with malignancy, high bleeding risk, or other absorption issues end up on Clexane for extended periods of time. And a number of them have issues with the psychological and physical burden of lots of injections. So there's the bruising, the pain associated with it. But through starting this study, we've sort of really realized that there's a lot more background psychological burden with people delaying their injections to the point where occasionally they miss them on days. And also, I think needle phobia is probably under-recognized in this patient group. So by using a subcutaneous catheter, we actually significantly reduce the number of injections, and it takes away that psychological aspect of having to pierce the skin with a needle. While Clexane or low molecular weight heparins can still hurt when you inject them, they can still sting regardless of whether or not you're using the catheter or just the standard injection. It does help patients, from what we've found so far, to not have that psychological, concern or worry during the day about when they have to inject themselves.
Okay. So can you give us an overview of your study?
So it's a fairly small study, but it's a prospective crossover study. So we're enrolling patients who are already on low molecular weight heparin. So they'll be having subcutaneous injections at the time of enrollment. They consent and sign on to the study and meet the criteria, they will then have the subcutaneous catheter inserted, and that will stay in for up to 7 days. And they have up to 3 peak anti-10A levels done during that time, as well as several visits to assess the site, phone calls as well if they require it. Following that 1 week, the catheter is removed. They go back to the subcutaneous injections. We have a minimum 5-day washout period, so that's basically they're just back on the subcutaneous injections. We just want to ensure that we've got an adequate number of half-lives while off the catheter before we do a further 2 peak anti-10A levels. Also throughout study, there are a number of patient surveys looking at their anxiety levels, interference with day-to-day activities, and more recently, we've developed a long-term extension study. So patients who finish the initial part of the study can then continue to use the subcutaneous catheter if they wish. To enroll on that, they get an independent clinician review. So they make sure that there are no medical or other concerns, that the patient is safe to go ahead. And they also review the peak anti-10A levels, and we have pre-specified criteria as to what is acceptable or not. And then the patient can essentially have ongoing weekly changes, 4 weekly medical reviews and anti-10A levels, and they can learn to insert the catheters themselves, so they can basically take the equipment home with them and do it all remotely. There is also a qualitative sub-study, so there is an optional semi-structured interview to further explore the patient experience with clexane or low molecular weight heparins using both methods. And also I should mention that this is open to patients on both therapeutic and prophylactic. And so with the analysis, it is separated into whether they're on therapeutic or prophylactic for some of the outcomes, and there are then combined outcomes as well.
Okay. You mentioned peak anti-10A levels, also looking at some quality of life stuff. Anything else there? Any other we missed?
Yep, we are also, sorry, I didn't mention the long-term follow-up. So we are following them out to 90 days. And there are questions around any symptoms of thrombosis or bleeding. So we are also looking at those outcomes, though with the size of the study, it's not going to be powered to detect any differences there. It's more a descriptive aspect of the study. And then finally, we're just looking at as well at the complications related to the subcutaneous catheter.
Okay, so sounds like a very interesting study. How do you see this study potentially changing clinical practice?
The hope is that we can show that it's an acceptable alternative, both in terms of the drug exposure and patient acceptance of the subcutaneous catheter. And that way we would then be able to offer it as an option to patients. So there may be some patients who want to exclusively use it or swap between the two methods, particularly, for those going overseas. A couple of patients who have been on the study have said that they actually preferred having the subcutaneous catheter when they're outside, going swimming, those types of activities, because they can just cover it up a bit more easily and they had less bruising on their stomach. Whereas others preferred to use the just subcutaneous injections sort of while they're away and then go back to the subcutaneous catheter when they came back. So I think there's a lot of flexibility in how it can be used, but I think the main thing is that it is an option, and I think it'll significantly reduce that psychological burden. And also with needle phobia and family members being able to assist with administering the low molecular weight heparin, I think that's also been a signal just from a couple of patients who have come through that's really helped them and their families.
Good to hear. So right now, you're competing in the Dragons Den competition, trying to obtain some funding. What are the next steps from here?
So the study is currently running at one site, so that's in Monash Health, Australia. We are trying to open in New Zealand as well at the moment, so that's in progress. If we were successful in getting additional funding, that would assist with going towards that, but we would also be interested in exploring if there are any other sites locally or internationally that might potentially be interested in joining in with the study as well to help with recruitment, because it is a tough patient group to recruit. So yeah, it would be nice to improve the generalizability and get perspectives from different places other than Melbourne, Australia.
Perfect. Anything else you want to add? Anything we haven't discussed you want to bring up?
I think that's the main bit, really.
Okay, awesome. Well, thank you so much for your time. Great hearing about your study, and wish you all the best with it.
Thank you for joining us for this special episode of Clot Conversations featuring the competitors from the Dragons Den competition presented by INNOVTE VTE. We hope you enjoyed the discussions with the three competitors, and we look forward to connecting with you again in our next episode of Clot Conversations. We love hearing from you, so send your comments, questions, and ideas for future episodes to info@thrombosiscanada.ca. Want to stay up to date on the latest in thrombosis? Click that follow button so you never miss an episode. And don't forget to visit thrombosiscanada.ca for a wealth of resources, including clinical tools, patient guides, and information on our annual conference coming up this fall. Your support matters. Consider donating to Thrombosis Canada to help us continue the fight against thrombosis.